The topic for today, as I mentioned already, is different approaches to therapy. And it is to give people a selection of different styles of therapy that is available. And it's not that it's limited to this, okay? But it's to help people to think more before they actually approach a therapist, or what might they want to know about a therapist, what way might they function, etc. So we've selected 4 people for our panel that are just different styles, and we've asked them, we've given them questions in advance, but we are open to other questions at the end. Can you tell us a little bit about your title, your role, and the type of client issues that you address in your practice, and the age of your clients, and tell us about some of the most common approaches that you use, okay?
Yes, sure. I can begin. My title, I have a master degree in developmental psychology, but I practice mainly as a behavior analyst. I have a certification as a BCBA, Board Certified Behavior Analyst. So I practice since around 14 years now. I work mainly, I'm sorry if I messing up all the questions at once, but
Don't worry.
I'll just give a broad presentation of myself. So my role is mainly to intervene as a supervisor of ABA educational programs that we set mainly in schools or homes of children with special needs. My clients are, most of them are diagnosed with autism spectrum disorder. Some of them have comorbidities like ADHD, intellectual deficits, motor physical deficits, and their age is, I would say, in between 3 and 11, 12 years old. I work in collaboration. It's very important for our approach to work in collaboration with other professionals. I usually set teams if I work with parents that need ABA therapy at home. I help the parents usually find a therapist that will conduct the sessions, educational sessions at their place. That could be 1, 2, sometimes up to 3 therapists working all together in collaboration, very often with speech language pathologists working outside of home with the child. In parallel, working also with a learning support assistant, helping the child at school. So this allows me to have a very comprehensive type of therapy, which includes also observations, assessment, program goals of other professionals. And also most of all work with the parents, because ABA therapy is most effective if all the goals we work on are able to generalize later on in the natural environment of the child with its caregivers, its family, siblings. What can I say else? Most of the approaches I use, it's a kind of complicated question, because generally speaking, the approach is behavior, ABA, applied behavior analysis. But within this approach, we can rely on a lot of different procedures, strategies of teaching, supports that we use. So maybe later on, if we speak about specific problematics, I can more specifically give examples of different procedures we can apply. And the populations, the problematics I work with are different, as I said, autism spectrum disorder, but the focus ADHD, developmental disabilities, but also the focus is most of all teaching the children functional skills, skills that will be important, socially important in their lives, that will allow them to be independent, to socialize, to increase their self-esteem, and to serve functional purposes for them. That is very, very important in our field.
Fantastic. That's really great. Thank you.
My title is clinical psychologist. I have a PhD in clinical psychology. I would say that I have two main roles. One is doing assessment, which is the smaller of my two roles. And I try to reserve my assessments for kids and adults now who are wondering about, who have attentional problems or executive functioning problems, or problems that are more related to a diagnosis of ADHD or a follow-up on in terms of school requirements for both the diagnosis and also for accommodations or recommendations. And more recently, as you all, well, many of you know, I do now assessments of adults with ADHD, which is a different process, but also really interesting. And the second of my two roles, which is the larger role, is as a clinical psychologist doing psychotherapy. So in psychotherapy, that could be individual with children and adolescents, and also I work with adults, as well as work with parents. I do a lot of work with parents. So that is, and that is definitely most of my time I spend doing psychotherapy, and I do an assessment when I don't do a huge number of assessments as some of my colleagues do. Let's see, type of client issues. Well, I see a very broad range of issues because there is a very broad range of issues out there for English-speaking clinical psychologists. I would say that my specialties are assessment and treatment of ADHD in children and adults, but I also do a lot of work with different kinds of anxiety disorders, and I do work a lot with OCD, with obsessive compulsive disorder, which is no longer categorized as an anxiety disorder, but and then a broad range of adaptation issues, all sorts of things that come my way. The age is also extremely variable, so it can be from, I guess the youngest are feeding problems with young almost babies, but I don't do a lot of that. I used to do that when I was in the States, but I don't, but I still like to do it. And it goes up from there to adulthood. Common approaches, I tend to work cognitive behaviorally, but I am informed by other types of therapy. So I think that the way I was trained, and also the fact that I've done it now for so long, means that my approach tends to be quite eclectic and to take things from various different approaches. But my base way of thinking is, I would say, CBT.
Fantastic. Okay, I think you've got all the questions.
I
Sophie.
wrote them down.
Oh, brilliant. I'll switch a light on.
I've written them down too. Let's see if I can do it
great.
without looking. So yeah, like Mia, I'm a clinical psychologist. I have a DClin Psy in clinical psychology, which is a training doctorate, which I did in the UK. So the kind of type of client issue, so really I work non-diagnostically, which essentially means that there aren't kind of particular diagnoses that I work with or don't work with. That said, the kind of clients that often come to me are commonly experiencing anxiety, depression, difficulties adjusting to kind of new life as an expat. So there are kind of similar themes for the people that kind of ask to work for me, but I don't sort of exclude any particular difficulties. The age is in terms of I suppose the talking part of it from children tends to be about sort of 5, 6, 7 onwards, and then I work with children, adolescents, and adults, but then also work with parents. So often, if the kids are younger, so babies or little sort of non-verbal people, I would be working with the adults around them to kind of support them. The type of approach I use. So previously, when I was in the UK, I worked using CBT, various kind of other approaches like that. Now what I offer is something called solution focused therapy, and it's really a therapy that focuses on people's strengths, abilities, thinks about where they're trying to get to, and helps them identify kind of resources in themselves or in the environment that will support them to head in the right direction for them. I do, like Mia, there are other things that I will hold in mind, but the bulk of the work will be using this solution-focused therapy. I think that's all the questions.
Fantastic. Back over to you, Aimee.
Okay, thank you. So I am a systemic therapist, and I work with families, couples, and individuals. I would say the youngest age of an individual I would work with would be about 15, but I'm really more focused on working with the family, with the couple. I have a degree in marriage and family therapy from the US, which is sort of what they call systemic therapy there. And so, yeah, I work mostly with families and couples. And so I see people for reasons such as, two new parents who are having trouble working together and coming together around caretaking, around the household, high level of conflict, communication, breakdown. Families come for different reasons, but I do see quite a few families who are concerned about very challenging or explosive behavior of children. And so when I said before that, I see my role as sort of supportive, because if a family comes to me and there's any question or concern about a possible diagnosis, then I refer them to someone like the good people and colleagues at Sprint who can do that kind of evaluation or testing, or and then if there are therapies that are needed, say something around sensory motor, then they will find the appropriate professional. Where I come in is more looking at, say, things that get in the way maybe of seeking help for a child. So such things as, it can be really hard to consider that your child might have special needs, might have challenges. And does that, it's like a process to go through for some people to reach out for testing or evaluation. And then if there is a diagnosis, how can the parents and the family come together to support the child, to make sure that the other interventions, are really being carried out, like to the best, they're supporting everything that's being done by the other professionals. And then, people might have a lot of mixed feelings about, about a diagnosis or about, a child's behavior. Now, there isn't always a diagnosis, but if there's suspicion or indication, then I always say, okay, here are several people that you could see regarding this. And that's, why Sprint is such a great resource. And so, so systemic therapists see the individual as part of a system of relationships, of behavior, of feelings. And so, I don't really look so much at the diagnosis and in itself, there's someone else for that. But how does that play out in the family? The behaviors or emotions or whatever we're seeing. How does that, how do other people react to that? How does the child react? And so looking at how to support families and make, so they can be as effective, as, supportive as possible. Am I missing anything?
No, I think you got it all.
Okay.
Fantastic.
Okay.
Thank you, guys. We're going on to the next question. And the next question, you can choose from, one or two of these particular areas and tell us what your approach would be to how you would address this type of problem. So things like anxiety, bullied at school, challenging relationships, lacking confidence, withdrawn from school, social challenges, behavioral difficulties with attending to tasks, following directions, disruptive behaviors, emotional regulation issues. I don't know whether you remember the list. I can rewrite the list, or I can even put it into the text. But if each of you can take one or two of those areas that you particularly like working with, or have a lot of experience working with, and say how you might address that. What approaches might you use, or what would you do to address that? Is that okay? Okay, and then let's mix it up a little bit. Let's say, could we start with Mia, go Sophie, Aimee, and then Nia? Is that okay? So could we start with Mia? Are you ready for that?
As ready as I will ever be. So I find this question very difficult to answer, and instead of just passing, I will talk about why it's difficult to answer. Is that because I think because these are all symptoms, and there can be many reasons for these symptoms. And so I wouldn't take a symptom and then apply a solution to it. I would have to understand what are some of the reasons that these symptoms occur. What is the context of this particular problem? So that is a big part of what I would do first. And then I think that without going into the specific types of problems, although if there are specific questions, I could talk about those, but really depending on what what some of the issues are related to a particular problem. Like especially if you're talking about something like anxiety, for example, there could be a million reasons that a child is anxious. Some of them might be individual psychological issues. Some of them could be learning issues. Some of them could be family issues. Among millions. So I would spend a lot of time. I mean, the first important thing would be to try to understand what some of the most important of those issues are. I guess what my work would involve would be working with the person, but also working with their system. So their families, their schools, if possible. I know there's another question later about school, but I would try to, and while sometimes the solution might be behavioral or cognitive behavioral, it would always be mixed with other things depending on what the particular problem is and what the particular problem what the particular reasons of the problem, for example, because, for example, anxiety, well, there are millions of things that you can be anxious about and a million reasons you might be anxious. So it would involve, you could be anxious about school, and that could be because there are social difficulties at school. That could be because there are learning problems at school. That could be because of bullying. That could be because there are family issues going on that affect their anxiety at school. So that's how I would answer the question. It's very hard to say, for anxiety, I do this, for behavioral, I do this. Certainly there are sort of techniques that I use more often, but they really would first depend on understanding what the problem is.
Very fair. Okay. Sophie, feel free to answer as you wish, or to pass and say you disagree and move forward. It's all correct.
No, I'll say, yeah, no, I'll definitely answer, because actually I think that perhaps my way of working is complementary but very different to Mia's way of working. So I think where Mia's kind of the kind of effectiveness of her approach comes from understanding the kind of origins of the difficulty of the symptom and making sense of the kind of the problem in order to then kind of think about moving forward. Really the kind of the focus of my work is that regardless of whether it's anxiety or lack of confidence or difficulties in relationships or any of those things that you mentioned, so people might come with, there is this problem in my life, and they might describe it, but really, in order for me to be an effective therapist, the main thing I want to know is what they want to be different. What are they looking to see? So often, for example, when people are experiencing anxiety, I'll ask them what they hope to be different, and they will say kind of less anxiety, which is obviously completely legitimate goal, but it doesn't allow me to ask useful questions, because I'm asking about the absence of something in their life. So for me to be useful, I need to know what they want more of. And often when people, for example, are experiencing anxiety, they're interested in more calm. Often when people are experiencing a lack of confidence, they're interested in experiencing more confidence. So the very first thing that I do is establish what better looks like. What do they want to see more of in their life? And then once you know more about what they're looking for, then I can ask questions to help build up that sense of what that would look like, where it's already happening, or what areas is it already happening. When it's happened before, what have the circumstances been like? So in understanding where somebody's trying to get to, I can then ask a series of questions which helps them increase the chances of generating ideas about what that would look like. And often in that kind of conversation, if somebody's interested in kind of increasing calm or increasing confidence in their life, as they describe the presence of that in their life, you can see that ideas come to them about what things they might do. And funnily enough, sometimes these really echo things that when I've been working, for example, using CBT, might have been something that I would introduce to them in CBT, but it's something that they've kind of either experienced before or they've heard of, that they can intuit that would be useful to them. And then in subsequent sessions, they'll kind of come back and have done a bit of that and have noticed that that's helpful, and then they can kind of build on that. So I think, yeah, again, not a kind of series of particular techniques, but more of a kind of broader approach to how you, how you respond to what's being brought.
Perfect. Thank you very much. Aimee, are you?
Yes.
Yeah.
Yeah. Right. So about anxiety, like from a systemic perspective, you know, if it's a child or a teen who's experiencing the symptoms, then, you know, I would try to have everyone come in, like everyone who is in the household, who's willing to participate, come in and try to find out, like, what is happening around these episodes of anxiety? What is the family's relationship to anxiety? Like, is this the only person who gets anxious, or do other people struggle with it as well? Like, what possible role does it play in the family? You know, because there's a side of anxiety that's helpful in a way, right? Like too little anxiety and you're not motivated, but too much and you become sort of paralyzed. So yeah, so does it serve some kind of role? And I don't know if anyone here has ever had this experience, like if you're with family members or a partner and you're in a stressful situation and one person starts to get really anxious and stressed out, then oftentimes the other person, you might feel just like, well, there's no room for me to get anxious because that person is sort of carrying the anxiety. So, I mean, that's just sort of an example of how we function as a system. And so sometimes in a family, you have like one person who sort of always gets angry, and they're the one in the family who gets angry. And then there's another person who gets anxious a lot, and other people have to be, you know, try to be sort of brave or encouraging. So sort of looking at it from that perspective, how do they talk about it? How does, you know, if someone's feeling anxious, how can they seek support from their family members? Let's see. But yeah, sort of like the history of anxiety, who else experiences it? And of course, like if they're, you know, depending on the age of the person and whether it's, you know, could be an adult, but you know, a referral, say, to a psychiatrist, you know, if it's an adult and they feel they want to get evaluated, or, you know, a teen, you know, to look at that piece if that's something that they think would be helpful.
Okay, excellent. Nia, would you like to select one of those? Do you want me to repeat?
That's okay. Maybe I will speak more about the disruptive behaviors,
Yeah, perfect.
which
Lovely.
sometimes might be related to anxiety.
Yeah.
Why do I choose that problematic? Because very often when we work with children with certain skill deficits as communication deficits, we often have to cope with problem behaviors because they are not able to express in a different, more appropriate way their needs, what they want, and what is potentially aversive for them. The general approach that we use in ABA towards disruptive behaviors is a functional approach, which means that we always need to conduct initial assessment. In the process, we always have to include this part. It's important because we have to understand what function does the behavior serve that person. which means that by this behavior, the person tries to communicate something. And in the process later on, once we know more about the function of the behavior, that will help us design a program, a plan, a behavior intervention plan that will help us at the same time reduce the disruptive behavior that person has, but at the same time put a lot of emphasis on teaching alternative behaviors, alternative skills. To give you an example, a child that cannot ask for something it wants, it cannot find a word, it cannot use the correct word, can have an explosive behavior in a certain situation. So in this certain case, we have to teach him most of all to be able to mount, to request what he wants to get in his environment. There are so many different reasons for disruptive behavior to happen, which necessitates us to have a very comprehensive approach. Not only we focus on the function of the behavior, but also we take into consideration in this initial assessment an assessment of the skills of that person, of that child. We have to have a very global view of what this child, the way it functions, what are the areas, big areas of deficit we have to work later on. I'm most of all thinking about because in my practice I work with children with severe autism, well functioning autistic kids. That's why probably I think about problem behaviors in teaching, language communication, because when we start therapy in ABA, we often focus on language, on requesting. When you think about the children, how they developmentally learn language, it's via requesting, via asking what they need. That's why that's a huge area of focus, communication skills. Of course, there exist a lot of procedures, and we adapt the procedures depending on a lot of factors. Very often, we need to have the resources in the environment. First of all, we need to have the parents' agreement. We need to have resources in terms of time. We don't want to use procedures that are very time-consuming for the family or for the staff. If you work with a staff in an institution, in a classroom, we cannot require a lot from the teacher, who have to cope with many other children. So what we suggest to put in place should be feasible, easy, pleasant. It should bring joy to most of all to the child, but also to the staff and the people who implement the procedure. Unfortunately, a lot of people, maybe when they hear about ABA therapy, maybe my colleagues will agree, think about some aversive procedures, some procedures that were very often used in the past that brought some negative opinion about our science, our field. That was unfortunately the case. In the past, we used a lot of what we call behavior modification procedures. The goal was to simply reduce a problem behavior, to make it disappear, so that it makes the life of that person easier, for most of all for the people around him. But today, our field has changed a lot. There is very important focus on ethics, on compassionate, make our approach more compassionate. And the trauma, we talk more and more about trauma-informed care in our field, which means that if we implement a procedure, we just have to assume that potentially the person we are working with was a victim of some kind of a trauma. That could happen very often with people who are not verbal, who cannot express what they want, what they have passed through. That's why we assume that, and we have to have a very smooth approach towards them, procedures that are potentially punitive, or even maybe most of you know about extinction, do not react, ignore, use plant ignoring for certain behaviors. That's something that we've used a lot in the past, and of course that was effective. We use it because it was effective, but nowadays we are just careful about that. We want to bring joy, happy faces, relaxation to the people we serve.
Fantastic. Thank you very, very much. And it's really nice to have a different approach, a different viewpoint. Okay. The next question, I'm just going to let you decide if you want to answer or not. Okay. And we can have everyone answer or nobody answer. How do you work with teachers, schools, and parents to help tackle behaviors that they're seeing? So,
oh, no, that's all right. Well, I was going to say, so I don't do at the moment in Paris, haven't worked with schools and teachers yet, although I'm very happy to. So it's more kind of from my experience of working with parents, but also sort of generally, one of the kind of approaches to tackle the sort of behaviors, because I will have had a conversation about what sort of behaviors, what people are looking for, and that will also include what sort of behaviors that people would like to see would be a sign of things going better. And so the kinds of conversations that I have support people to be more likely to notice the behaviors that they're looking for. And it sort of works. It's not officially this, but it sort of works as a kind of an attention training program that you are aware of what you would like to see, and there you look out for it in your environment, you see it. We also kind of have conversations about, if you were to notice that, how would you react? And they might describe, well, I'd be shouting less. And if you were shouting less, what would you be doing more of? Well, I'd be, perhaps being more playful, or, more calm, or whatever it is. And so in the conversation, it helps both describe the behaviors you'd like to see, but also sort of highlight how you might behave differently, and the impact that might then go on to have on the behavior for the young person, and the impact that might have on you, so that it then becomes a sort of interactional thing as well, where you're increasing the chances of catching good things happening, and then allowing that to have more of a momentum. So,
fantastic. I remember using that at a school. It's like noticing good things,
yeah.
Perfect. Anyone else want to raise their hand from the panel? How you would answer that, Aimee?
Yeah, I mean, like Sophie, I don't work with schools or in schools. I work with parents and the family and the child in the context of the family. But sort of, if we take the idea of a disruptive or really challenging behavior, or no, let's look at emotional regulation. So if you're seeing a child frequently melt down, really struggle with emotional regulation, sort of reframing that for the family and for the adults as, this is a child who's struggling, who this is the sign that they are not regulated, they are stressed, and start to explore what underlies that, rather than seeing it as defiance or non-compliance, or just bad behavior, in quotes. And then after that reframe, sort of looking at who else is struggling in the family with emotional regulation. And if someone is melting down in front of you, it can be hard to stay emotionally regulated. Parents and kids or teachers for that matter. It's like a constant feedback loop. And it's hard to maintain calm when you're worried about, a huge meltdown at, a difficult, inopportune time. And then sort of looking at how can the adults sort of foster, work on their own emotional regulation, both for their own benefit, but also as a way to model it and provide that sort of, balance in the family and with the child. So.
Fantastic. Thank you. We've got Mia and Nia. Would either of you like to?
I can
Mia?
go.
Perfect.
So what's the question? With schools
I'm
and
going to read the
parents,
question.
right?
I'm going to read the question again, just to bring back to mind for everybody. How do you work with teachers, schools, and parents to tackle behaviors that they're seeing?
Okay, so parents, I think I've spoken about, because I always work with parents, and that is even it's a rare kid where I don't see the parents. It really has to be a very, very particular reason. But obviously, in terms of confidentiality, I would handle the seeing the parents in a different way with an adolescent than, I mean, I would always take confidentiality seriously, but I would handle it differently for adolescents and for younger children. But I always include the parents in some way, even if it's just periodic check-in, or they may be a more active part of the treatment. For younger kids, sometimes I see almost exclusively the parents, because I think that they have a lot of agency in how to manage their kids and make the kids feel more secure and respond in different ways, much more effective than some strange therapist seeing them in a room. So that's the parents. If schools, I really, really try to work as much as I can with schools. If the school, if I can do it, I love to do observations. Although I can't always do it, and they don't always want me to do it, but I try. And I'm always open to working with teachers, with whoever is working with the kid in the school, in order to both get more information, and I'll always be very clear that I will do that, or with the family, and get their permission, of course, either with someone who's working with the child, or well, however it can be useful to them, both to get more information or observations, or to know more about how a child reacts in different kinds of settings, as well as to try to maybe provide some insights into what's happening for this particular child, or suggestions about what might work, different ideas about what might work to help them. So I try for that to be an active part of what I do. It's not possible in every single case, but that's always my intention. Or with often in the bigger Anglophone schools, with the guidance counselors, like at ASP, a lot with the guidance counselors. So that is that's great, because that's it's a more direct contact, and then sometimes they can contact teachers or parents, or they're super helpful, and it's very helpful to be in touch with them. In terms of, and I want to add to this, although it may be a separate question, but working with other professionals is also very important. for me. So if there are more than one person working with a family or a kid, I will always try to have some sort of contact. Sometimes regular, sometimes just once in a while, sometimes just once, but to really try to get a coherent way of working and to understand what the difficulties may be with the child in certain that I'm not working on directly, but that can be would be important in understanding the child more fully. One of my proudest moments was that I was working with this family. They were not, well, yes, actually the parents were both French, but had spent years in the States. And they had, each person in the family had a therapist. And except for me, they were all French therapists. And I managed to get us to have a meeting together, all the therapists, which never happens. They were very shocked at this idea, but they did it. And we had a very productive, useful conversation. And it was a lot of work to get them to do that, because they're all, they're not used to doing it that way. But they all agreed, and it was really, really great. So I think even in situations where it's not the common practice, it can be possible.
Nia, would you like to talk on this subject? Again, how do you work with teachers, schools, and parents to help tackle behaviors that are they're seeing?
Yeah, of course. I work with in the different environments the child lives in. So in the school, with the parents, also with other professionals working with the child. It has happened to me that colleagues contact me because they have problem conducting their sessions, speech language pathologists who just have to face a lot of problem behaviors, and the child is not able to sit in front of her and to accept any instruction she presents. So it's very important in the process that first of all, for the assessment part of the process, that I'm there in the environment where the behavior happens. I always include the caregivers or the staff or teachers' observations in the process. It's very important because they actually know the child better than me. They interact with him, they see him, they see the problem behaviors every day. So I try to have them translate the problem behaviors in words via interviews. We just have these conversations when we form hypotheses about the problem behavior. It's very important that I am also there because I have to observe it happening. It's the observational part, very important in the ABA field. Observe, take notes. Of course, there is a third part of it, which is more analytical. We call it the functional analysis. It's the experimental part of the problem behavior, when we have to understand the function of the problem behavior, which very often we are not. It's not necessary to implement. We don't implement because it's not feasible, but it's necessary. But for cases where it's really difficult to understand what the person communicates via the behavior, it's very, very important to conduct this part. Also, in the process of managing the problem behavior, I speak with the person, teacher, parents, about actually understanding the principles of behavior. I try to explain to them that every behavior is learned, and that can help reduce the tension, the stress, because if it's learned, it can be unlearned if we implement the right strategies. The behavior is there because it's reinforced in some way, because the person feels that she can get some positive, some pleasant consequences, feeling of having this behavior. So it's very important for the parents to understand that in some way the theory behind what we're going to do. it helps us also not be perceived as someone very directive who comes and who in their place and who only gives recommendations. You have to do that, and it's important for me. This is maybe the way that I work also, to always explain, always be sure that the person understands what we are doing and why we're doing it, and towards what goal we are doing it. Also, a lot of the focus is on preventive strategies in our field. Understand that we don't have to provoke a problem behavior. We don't have to expect it to happen, but rather prevent it, teach the appropriate alternative behaviors to that person, or implement environmental changes, accommodations, modify something in the environment so that the problem behavior doesn't have to happen. And it gives more sense of control to the person at the same time. This is a very smooth way to work with the person, helping him to communicate his needs, but also to smoothly start to tolerate what could be potentially aversive for him. It's a very smooth and I think a very ethical way to work, rather than, again, just focusing on the behavior, reducing it, and leaving that person with no alternative, nothing that he has learned. And again, I think, as Nia said, it's important to work with all the people at the same time. So if we implement a certain strategy, certain supports, modifications, we all apply them at home, at school, so that it helps bring more consistency, more coherence in the therapy, rather than having different approaches, giving different reactions to a problem behavior happening.
Okay, thank you. Question that came from basically, this question can probably be answered by one of you, and even between you, and I might even throw it to Seta, who probably is unsuspecting. But when do we refer to neuropsychologists, and what do they do that's distinctive from other psychologists? So I don't know whether I'm going to maybe ask Mia or Sophie or Seta if you're there and present and open to answering, perhaps to go for that one. Sorry to put you on the spot. Well, I just thought that, it was an opportunity to bring you back in,
I think actually I'm pretty sure that Mia and Sophie would be able to answer that question as well. So, but since I'm here, I guess I can answer. But I would like to hear what they say as well as the others would say when they would refer to neuropsychologists. As a neuropsychologist, I would say when they feel like it's something beyond emotional or beyond what they are able to treat or address with the therapy. So if it comes to the point where they're seeing there's something that might be more helpful to see if there's something neurological going on, neurodevelopmental going on, and it would be beneficial to have more understanding of their cognitive functioning, right? Mm-hmm. So sometimes we want to understand, is this child, do they have a cognitive functioning that's at the average, or is it below average? Or maybe it's well above average. Sometimes giftedness is a question. Very high average functioning is a question. So neuropsych testing partially includes that kind of role. But then beyond just getting their IQ or intelligence, we would look at things like, if there's a question about, is visuospatial functioning a big issue here? Like, is this child not able, seems to be having difficulty discerning faces, discerning, getting around in space, have a very hard time with drawings and writing and things like that, so that maybe there's some aspect that we have to look into to get the child better accommodations at school, better understanding at home. Issues of language, which I would think, you know, working with a speech therapist is also very important. Working with a psychomotrician or occupational therapist is also very important. So knowing not just when to refer to a neuropsychologist, but also when to refer to the other therapies out there. So, you know, is there a language understanding issue? Is there a comprehension problem? Should we look at that? Is some of the behaviors that, or the anxieties the child is going through because of that? Other aspects could be memory. There could be, then you have to look at things like, you know, if the child has a lot of behaviors that seem unexplainable beyond attention. I mean, obviously there's an attention issue, if there is a language issue, so on. If the child seems to be zoning out a lot, or has some repetitive behaviors that might be best to look into to see if there's something else going on in terms of neurological. Maybe there's you know, seizures of some sort, which would then a neuropsychologist can look at, but then we will have to also think about when to refer to a doctor, right? So in terms of neurology. But I don't know. I'm actually quite curious as to
the others would say.
Yeah.
Okay, guys, you're up. Who would like to respond? And thank you very much, Sasha, for jumping in there. I appreciate it.
Yeah, I can. Yeah. Well, as usual, I completely agree with Seta. That's exactly what I would have said. That's what I do say. I think that well, I would say that there are a number of psychologists, of clinical psychologists in Paris in particular, not everyone, but I would say probably more than the average in another country, that have learned to do neuropsychological testing because we had to, because there was no one else around to do it, especially in English. So I think that there are probably, that for more standard things, I think that we can do a lot of the more neuropsychological things, but anytime there seems to be a case which seems quite complex, in which there are a number of things going on and a number of unexplained things going on, anytime where it seems that there is potentially some neurological involvement. I know that Seta and other neuropsychologists know much better than me how to identify those things, so that would definitely be a time I would refer. I guess, honestly, I would refer more for visual spatial unusual things than for language unusual things, but that just maybe just me. But I think that that's an area that the specific knowledge of a neuropsychologist can be very helpful. So yeah, so I mean, I'm repeating a lot of what Seta said, but I agree with her, and I think that we can work together a lot, you know. And also there are neuropsychologists who are more focused on neurology, and there are neuropsychologists who are more focused on psychiatry. So it really depends also on what you believe, you know, what your theory is on what is happening and what you would like assessed better. So, and I'm wondering if we can also ask Jamie, because she does a lot of evaluation.
Jamie, would you like to pipe in?
Sure, that's fine. I also completely agree with you and Seta. Yeah, I'm sort of like you in that I have for me, I have my bag of neuropsychological tests that I know how to do and I'm comfortable with and I've been trained on for a long time. But when it goes beyond, when it goes to that visual spatial, I'm the same way in terms of when there's just things that I haven't spent a lot of time with, and I know that's when I need to refer to a, you know, a more equipped person in that specific area. When it comes to my background in terms of it's more educational psychology, so in terms of all of those pieces, the from attention to those kind of things, I feel like that I'm very I get and I understand, but when it gets to that next level, that's when I seek out a neuropsych, and I'm completely willing to send them away to because I know my limits of I think I have a lot of I have a lot of background in that, but there are pieces of certain parts of memory, certain parts of different little pieces that I A, don't have the test for, and B, don't have that overall picture in terms of neuropsychology, if that makes sense.
Can I ask Sophie, and thank you very much, Jamie, for jumping in there as well.
problem.
But Sophie, your approach is coming from the British side, so I don't know if there are little nuanced differences and whether you would have a different response.
So not a different response. I don't think there's differences between the UK, and I agree with what's been said so far. And I would think I would just add that my clinical work is non-diagnostic, but I think that diagnosis is really important to open doors, to open possibilities, because sometimes there are situations for young people where something's going on, they're not being able to sort of access learning as they usually would, or that there's or as kind of perhaps a typically developing young person might, or that there's kind of something going on that's blocking and causing difficulties, and then I think that being able to kind of refer to a neuropsychologist to do those tests to kind of establish definitively what language and what structure we can use to describe those difficulties can then help the systems around that young person, whether that's the family, the school, anything, support them better. So, for example, a young person who there are attention difficulties who then go on to have a diagnosis of ADHD, it means that the system around them can just respond differently because there is a diagnosis which makes sense of behavior that perhaps before was being interpreted in a different way. So I think it's I'm very, even though I don't work diagnostically, I think that diagnosis has very, very important role to play in terms of children's sort of development, access to, well, the education and well-being and kind of systems around them, kind of understanding more about what's going on, where the difficulties might lie, where the strengths might lie, and how those can be kind of helped.
Fantastic. Okay, we've one more question on our schedule, and then after that, there may be a question or two. There may be time for a question or two. We'll try and finish at 9. Yeah, of course. Sorry.
One little thing. I'm sorry. I just want to say quickly that I agree with everyone who has chimed in on this, and about the importance of referral and the importance of accurately understanding, what the challenges are for the person in question. And I might also refer to medical doctors at times, because especially when you're looking at children's behaviors, disruptive behaviors, for example, say pain can be an issue, like a child with sort of unexplained stomach aches, headaches. And I once read from a wise person, don't turn a medical problem into a psychological problem. So I wouldn't assume that the stomach aches are related to any types of, relational difficulties in the family. The risk there is that you're going to miss a significant medical problem, or a problem that can be treated and therefore eliminated as a source of stress and difficulty.
Absolutely, that's a good point. Okay.
Can I just add one thing to that? is it? Yeah, that is one thing we forgot really to talk about, because in terms of a team, as a doctor, I agree with you completely, Aimee. I think that doctors can serve a very important role, and I really like to try to get them involved, especially if there are things medically that have been, well, that either other people have told the person is psychological, or that they have assumed is psychological. And so, quite often I'm not so sure. So I would always send them to a doctor. However, there are other things, and I forgot to talk about this, is that I work a lot with psychophysiological things like migraine and recurrent abdominal pain and things like that. And that's multidimensional. So I would say that in those cases, I would definitely work with doctors, but that there is a role for psychological approaches to that as complementary or as part of the treatment. So it's not, for me, those kind of disorders are not either medical or psychological. They're a mixture of things, and different people can play different roles. But there's certainly times when people say, I know this is just stress, and the symptoms are unusual enough so that I'm not so sure that it's just stress, or even that you should say just, but that it's worth a fuller and more complete medical exam. So thanks.
Okay, thank you. Okay, so this next question, understanding that there can be an overlap in types of therapies used or roles that people play in working with a child, what kinds of questions should a parent ask potential therapists when searching for someone to work with their child? What advice would you offer to a parent looking for a therapist of some type? What kind of questions should they ask? And I don't know, like, if I'll let you put your hand up for that. Sophie?
Yeah, this isn't necessarily a question to ask, but I think one of the things that's important to bear in mind, and particularly with kind of therapies, is that actually lots of therapies are effective. So there are lots of different options that you have. And I think it's sometimes a little bit overwhelming or bewildering for parents when they think, should I be going for this kind of therapy or that kind of therapy? So that's a kind of, that can be a bit sort of tricky. Partly it's perhaps understanding more about the therapeutic approach of the person that they're talking to. What can they expect from sessions? What sorts of kind of questions, what sort of outcomes, etc. But also sort of, I suppose my main point is that the really important part is the relationship. Is this, when they speak to that therapist, that psychologist, do they get a good vibe? Do they feel like this is somebody that they want to talk to, that they would feel comfortable talking to? Can they imagine this person having a good conversation with their young person and bringing what they feel like their young person needs into the room? And that's an important thing to calibrate to, because you deserve, and I'm confident that this is the case with lots of, of all of our Sprint members, and lots of other kind of people working with children in Paris and around, that you can expect to have sort of great professionalism, great empathy, but also for parents to kind of tune into, does this feel right? And if it doesn't, that's all right to kind of not work with that person if it's not feeling right for them.
Yeah. Okay. Would anyone else like to speak on that point? Or
yeah, well, I agree with Sophie completely. I think it's how comfortable you feel, and if you're comfortable with their approach. I'm kind of a stickler, so I would also ask what their background is, what their qualifications are, and and if they are licensed anywhere. I mean, those are things they're not sufficient, but I think they are necessary. I know that everyone doesn't agree with me on this, but I really believe that qualifications and degrees are there for a reason. So if you should ask, I think a parent should ask those things, and then see whether it seems like a good fit. And there are particularly certain types of problems where there are empirically validated types of therapies. So yes, it doesn't always work with every person, and there is a wide variety, but especially with children and with vulnerable children, I think that it's important that you look at what is empirically validated and what you think is supported by research, and then find someone who has those qualifications and you also feel comfortable with and feel that they are a competent person and that they could make your child that you're it. So look at both sides of it, or many sides of it.
You froze there, Nia, at the end, but I think we got the gist of the last sentence. Okay. Aimee or Nia, would you like to speak on that question?
I agree with Nia about the last part. I'm sorry, I didn't hear what the last sentence. There was a problem with the connection. But talking about the evidence-based part of the practice of that professional, I think it's very important for the parents. If they don't feel comfortable asking about that approach, at least try to read a little bit about it, try to understand or rely on their network of other parents using that approach and understand a little bit more about what it consists of, and if it's evidence-based regarding the concrete problematic they're having, because some therapies can be quite effective for certain problematics, but not for all. So it's very specific. I would also say that ask the parents maybe to ask how the sessions will be conducted. Are we talking about a highly structured approach, quite structured approach, which could be good for certain problematics, as working with a child with autism, for example? Are we having a professional who is conducting issue assessment, who will define a program with specific goals we are working towards to? Those are important questions, I think, for a parent to ensure that the professional will be transparent enough during the therapy. I think it's important that the parents feel they're part of the therapy during the process. So they should feel free to ask those questions. And also if they will be asked for their agreement for implementing any procedure, any change in any procedure. That's very, very important in our field.
Excellent, thank you. Aimee, would you like to say anything?
Yeah, I like what everyone said so far, and along with the idea of asking about, sort of their attention to research or importance of evidence-based practice. How do they keep up with all of the new research and evidence that is being generated? So is there any kind of continuing education or training or supervision, those kinds of things that, because the field is changing so fast. There is so much research that, our understanding of development and the brain and behavior has just really changed so much just since, I got out of school. So how can you keep up with those things? And then, particularly if it's parents who are asking, who are inquiring, like, what role, if any, can they play in the therapy? Even if it's individual work with the child, how can they be as supportive as possible and collaborate?